So let's take a look at chapter 20. When we look at chapter 20, it is all about the heart and how the heart works. And when you take a look at this picture right here, this kind of looks like a slimy scorpion tail. In reality, this is actually one of the big bulge of cardiac muscles that we find inside of the chambers of the heart. All this sinewy white material, this is called the chordae tendineae. This is a connective tissue that allows the heart muscle, the myocardium, over here that's bulging out, so that to link that heart muscle to the valves. So this chordae tendineae are the almost tendon-like structure that allows this heart muscle and all these other heart muscles to contract and close valves. We're going to see in a second that contraction of the muscles as well as pressure is what allows certain valves to open and close. So let's discuss this in terms of functions, right? Pretty easy to understand. Function of the heart generates blood pressure. Blood pressure is very important, even though I know everybody's scared about high blood pressure. Low blood pressure can be just as deadly. So generating blood pressure allows us to move blood against a force of gravity. Without that, you're not going to move blood to the brain, the one organ that really needs it. Then we can route blood, meaning when we're exercising, we want to route blood in different ways. And right, routing blood means we're going to separate the pulmonary circulation from the systemic circulation. Keep in mind, pulmonary circulation that we'll talk about is going to be very, very low pressure. The heart is very close to the lungs. The lungs, because it's full of oxygen, also is going to be very wide open, meaning that the blood vessels are very vasodilated. The more vasodilated a vessel is, the less pressure required to move blood through that vessel. Now, also keep in mind that when we have any kind of diseases and the oxygen levels in the lungs start to drop, let's say coronavirus, it's going to have an incredible effect on blood pressure to the lungs. Because if there's no oxygen in the lungs because somebody has pneumonia, what occurs is the opposite. When oxygen's high, pulmonary vessels vasodilate. When oxygen levels are low in the lungs, the opposite occurs. They vasoconstrict, making it harder to move blood into the pulmonary circulation. We'll talk about how they are separate and how the left and right side of the heart really have different amount of heart muscle, right? Because of that, we have the huge difference in pressures between pulmonary and systemic circulation. Valves ensures one-way blood flow through the heart. So then when you hear the word valve from now on, the main purpose of any valve, and we'll see valves when we talk about chapter 21. Chapter 21 is blood vessels. Valves are very important in helping blood move up veins. Valves are also seen in the lymphatic system. So valves, this is just the first time we'll discuss it. And the main purpose, though, in any of those instances, as well as in the heart, is to move blood in one direction. We don't want backflow. Then, function of the heart includes regulating blood supply. What we're going to see is the more active tissue. Obviously, if the tissue is active, it needs more fuel. And fuel means blood. So you want to bring blood to areas of the body that is more active. So when you're exercising, you're going to have more blood going to the areas like your skeletal muscles, right? And we'll talk about more of that in chapter 21. Again, the big one is this: the more active the tissue, the more blood it receives. So here's that diagram. Again, right? When we're bringing blood to the lung and the lung capillaries to oxygenate, all we're doing is moving that blood a few centimeters. That's it. The lungs are very, very close to the heart. Whereas when we're moving blood to, let's say, your fingertips, that's pretty far away. How about your toes, right? If you're bringing blood to your toes, that's really far away. So you need to pressurize that blood more to bring it to your distal extremities. And you're going to see in a second I do have a cardio a cardiovascular anatomy video for just the anatomy that allows us to differentiate which heart and which side of the heart is which. So let's take a look at this, the shape and location. Look at how close the heart is to the lungs. The lungs are very intimate to the heart. The lung itself is going to be so close that in order to visualize just the lungs, right, it's really hard to see it on an x-ray because a heart is in the way. So we'll talk about it, hopefully. I know I have some videos that shows it as well. The diagram doesn't really do it justice because it's so close that even a part of the lung matter itself has a window just for the structure of the chambers of the heart. So it's incredibly tight fit. Here you can see how tight of a fit it is. And again, the heart itself, because the heart is going to be contracting. At rest, it contracts at 60 beats per minute if you're in good shape. The lungs are expanding at 10 to 12 breaths per minute. So what happens if you have two moving objects right next to each other? What happens is you can create a lot of friction. And to prevent the friction of the lungs expanding, inflating, deflating 10 to 12 times a minute, the heart contracting 60 times a minute, sometimes even more if you're working out, 120 times a minute, 150 times a minute if you're working out hard. Well, what happens is we need some connective tissue here, covering the heart, connective tissue, covering the lungs. And the connective tissue prevents the frictional forces of the two organs here that are moving asynchronously, and even more importantly, that could rub against each other. So you have the connective tissue called the pericardium here. And the pericardium protects the heart from the movement of the lung matter itself, as well as the movement of then the ribs. Now the pericardium contains a fibrous external region, tough, dense, regular connective tissue, prevents over distension, prevents frictional forces, also acts to anchor the heart to the mediastinum, the central area of your thorax. Then the serous pericardium has two parts. The parietal pericardium is part of the serous pericardium, and it lines this outer region. So I don't know if I can see it. So right here, this outer region in blue, that's the parietal pericardium. And then the visceral pericardium lies directly on the surface of the heart and the external heart wall right here. Now, the visceral pericardium is also known as the epicardium. Those things are used interchangeably. This is very similar in 201. And I like to use analogies for 201 because if we don't, I mean, most people are going to forget about 201. So the analogy is this. Do you remember when you guys talked about the meninges? The meninges in 201, there's a dura mater. The dura mater is that fibrous pericardium, very external. I don't know if you can see this, but if you take a look really, really closely, there's this white outline right here that's dense. That's a fibrous pericardium. Then on the inside of it, well, the analogy is this fibrous pericardium is like the dura mater, tough, thick connective tissue. Then inside in between, sandwiched in between, is your arachnoid mater in the brain. In the heart, this is the parietal pericardium in blue. Now, in the brain, underneath the arachnoid mater in the brain separates the dura mater from the rest, right? And then you have the arachnoid mater lining the inner lining of the dura. Here, the fibrous pericardium, very tough external, like the dura mater. And then, like the arachnoid mater, you have the parietal pericardium lining the inner wall of the fibrous pericardium. Now, the analogy is usually pretty good because if you remember it, the arachnoid mater, deep to it, that's where you see the cerebrospinal fluid. So the arachnoid mater, then deep to it, you'll see fluid. Same thing here. deep to the parietal pericardium in blue, you see a little bit of serous fluid, pericardial fluid, that allows you to bathe the heart in that fluid. Now, the good news is it bathes the heart in the sodium-rich fluid. So then it increases a probability of action potentials. The bad news is sometimes that fluid can get infected, sort of like what we see in meningitis, right? So again, very similar. And just like in the meninges of the brain, the glia, right? Actually, the pia mater is adherent to the brain. Here, the visceral pericardium is actually adherent and is the epicardium. So it's adherent to the muscle of the of the heart itself over here. So analogy is pretty good in terms of understanding. If you understood 201 and you understood meninges, is a very similar construction here. Now let's take a look at the main functional area of the heart. So the epicardium, external, also known as the visceral pericardium. Then the myocardium is the most important part. This myocardium is also known as cardiomyocytes, also known as cardiac muscle, and it's responsible for the heart contraction. So the myocardium has lots of aliases, lots of other names. And the myocardium is going to be important because this is the functional area where it causes contraction and eventually blood movement. Inner lining is nice and smooth, right? Remember, we do not like anything rough. And this is found in nature, is found in even our plumbing system. If you look inside of a PVC pipe, on the inner wall of the PVC pipe, the inside lining should be nice and smooth. That smoothness then creates this ability to have nice, efficient flow. Now, in the pipe is efficient flow of water. In the body is efficient flow of the blood itself. So this myocardium, also known as cardiac muscle, also known as cardiac myocytes. Well, this muscle is then lined internally with a nice layer of simple squamish epithelium that allows you to lubricate the inner lining. So then as blood moves through it, it moves more efficiently as you pump blood through the heart and then eventually into the great arteries. Now the pectinate muscles found in the auricles and the right atrial wall, right, is found deep inside here and allows for a little bit of contraction. Right, the trabecular carne, muscular ridges. So this is trabecular carne. The trabecular carne are the actual muscles, the cardiac muscles that kind of move outward right here. And it forms, right, trabecula. Now again, trabecula, you might not remember, but we had trabecular bone. Trabecular bone had the very similar look where it doesn't lay flat, right? This is not flat. It's nice three-dimensional, right? Parts of it stick upwards. That's the ridging that we're talking about with trabecular carne. So take a look at this right here. Now, this is obviously a diagram, right? This is the cadaver picture of it. I do have a nice video on the anatomy, right? And I show it on both the cadaver and on diagram. So make sure you take a look at those. And then next week, we'll go through more of the arteries. And then we'll do like in a couple of weeks, do a practice together. Well, I'll show you a couple pictures and you got to tell me what the actual things are. So hopefully that can help you as you try to figure out how to do lab practicals. Now, let me see if anybody's here yet. Nope, just me and you still. So it's okay though, you get personal attention. All right, Amanda. So Amanda, have you taken the 201 class where you have to take lab practicals? You can just, or you can tell me.
I did, but that was during the summer and it was online, so it was kind of weird. It was more
Diagrams and pictures?
yeah.
Yeah, that's what it's gonna be. There'll be pictures of models. There'll be pictures of cadavers. And I
Okay.
think what we're gonna do is when we get closer to it, like the week before, I'm gonna have practices, all right? So
Okay.
then you can figure out how to go through it, and then we'll go through it together as part of our 2-hour lecture thing, okay? So
Okay.
then it won't be a shock to you.
Okay, that sounds good.
Good. So let's take a look. Who did you have for 201?
Uh, I forget her name. It was like Layla,
Leah.
Leah. Yeah.
Leah. I love Leah Holmes. All
Yeah,
right.
she was good.
So now let's talk about the coronary arteries. And I do have videos on this one, but when people have an MI, a myocardial infarct, again, I want us to get used to using very specific terms, right? So we don't like to say heart attack. Why? Well, what is a heart attack? Is it because you have a blood clot? Or is it because you have an arrhythmia causing your heart to stop? By saying heart attack, we can't tell the difference. The treatment for an MI is completely different for the treatment when somebody has an arrhythmia. Right? When somebody has arrhythmia, you need to shock them back into normal sinus rhythm. You've watched those, movies, or you watch videos, you watch TV shows where they put the paddles on and they make everybody clear and then they shock the body. Well, that is the only time we do that is when we have an arrhythmia. Now, if you have a myocardial infarct, it's a blood clot along either the right or the left coronary arteries. Now, the worst is if you have one close to the very starting point of your left coronary artery. This one artery that comes out, the book will call it the anterior interventricular artery. I don't have that at all in my models list. Instead, on my models list, I have it as LAD, left anterior descending. Doctors, even nurses, like to use acronyms. And when all hell breaks loose, you'll see that there's another artery called the posterior descending artery, or posterior interventricular artery back here, and then an anterior interventricular artery. When all hell breaks loose, all you hear is interventricular artery. That's it. So we want some words that are completely different. So then there's no mistaking it. Calling this LAD, left anterior descending, calling the one in the back PDA, posterior descending artery. Well, there's really, there's no vagueness there. LAD is very different than PDA. So we use those terms clinically, and you will use those terms when you're doing your wards. That's why we are going to use those terms. So LAD is the single most important artery in your heart right here, right? Besides the left coronary. LAD supplies all the blood flow into the left ventricle in the anterior surface and part of the septum. And the left ventricle is going to be the main pump. And we'll talk about how we deal with MIs later on. But keep in mind, when we have a myocardial infarct, you have a blood clot that's found in one of these branches. The big widowmakers occurs when you have a big branch of LAD that's occluded. Now, when you have an MI, we'll do balloon angioplasty. We can do TPA and, TPA treatment, tissue plasminogen activator that we talked about in chapter 19. Or if you're more stable, we can do CABG, which is coronary artery bypass graft, where we harvest a blood vessel from somebody's leg or arm and then reattach it. So then even though the vessel here is occluded, what happens is now I reattach it afterwards, right? Post clot. So guess what, right? We're reestablishing a new flow, which is good, right? Now, again, I'm not going to go through this too much because I do have a video on the anatomy, and we'll go through it as well next week on the anatomy. Now, the heart chambers, obviously you probably have heard of this, right? There are 4 main chambers. The 4 chambers are on the right side and the left side slightly different. If I'm just going to take this picture and move it over a little bit so we can see, take a look right here at how large the walls of the left ventricle are compared to the wall of the right ventricle. That's a big key, right? I remember having to kind of, when we first started to do more dissections, I've had to kind of instruct other instructors on how to tell the difference between the right side of the heart and the left side. You think it'd be easy, right? When you're dissecting a pig heart, when you dissect it, a sheep heart or a cow's heart and pig's heart are pretty big. Pig's heart are about the similar size as ours. And what happens is when you look at it, the front and the back looks very similar. When you look at the sides, it looks very similar. You can usually tell where's the top and the bottom, but because there's so much fat in the hearts, it's really hard to tell where's the left side and where's the right side, especially if you don't know which is the front and the back. So I always tell them, and I always tell my students, in order to really tell which side is which, I always have my students find the apex. Again, usually you can find the apex, which is a tip right here, and then cut with a cut that is a coronal cut, right? Cut it into front and back. So we cut it from that apex and to the side, like we did here. As we do that, now we can see which side has larger amounts of cardiac muscle. The side that's thicker in cardiac muscle, that's the left ventricle. Left ventricular pressure during contraction goes up to your systolic blood pressure. You've taken blood pressure before. You probably, I know everybody's gotten their blood pressure taken before. Systolic blood pressure is the blood pressure measured at the left ventricle at full contraction. About 120, right? 120 millimeters of mercury. Now, you would think the right ventricle would be very similar, completely different. 120 millimeters of mercury, that's your systolic blood pressure. That's a pressure in the left ventricle. Your right ventricle, because you're only moving blood to the lungs, and because the lungs are healthy, the blood vessels, the pulmonary arteries here, the blood vessels are vasodilated. So what happens when blood moves up into the pulmonary trunk, into pulmonary arteries, there's less resistance. So it takes less pressure to move that blood. The blood pressure in the right ventricle is about 25 to 30 millimeters of mercury. Usually it's about 22, 25. So it's about a fifth of what we see in the left ventricle. So that's a huge difference, right? 120, 25. Big difference between these two chambers. Now, the right atrium, left ventricle, right ventricle. Separating the atrias from the ventricles are our valves. The right side, the valve is called the tricuspid valve because it's got 3 cusps. On the left side, that valve is called the mitral valve. Right now, again, bicuspid, tricuspid. When all hell breaks loose and somebody's crashing, all you hear is cuspid. So we use words that sound completely different. So tricuspid valve sounds very different than mitral. There's no way you can mistake that. That's why we use mitral instead. Now, most of you, usually in a normal class, we have about 24 students, and 20 of them are usually females. Usually with females, you have a probability of mitral valve prolapse. It's a very silent, right, very asymptomatic kind of condition. And the mitral valve prolapse means that during contraction of the left ventricle, the mitral valve gets pushed a little bit towards the left atrium. It prolapses there, right? Now, again, it sounds dangerous. It isn't. But we don't call it a bicuspid valve prolapse. We call it a mitral valve prolapse, right? So the left ventricle then is going to eject blood to the aorta. In the process, it has to open the aortic semilunar valves. Remember, these valves are going to open and close due to pressure changes. On the right side, the right ventricle ejects blood into the pulmonary trunk through the pulmonic valve right here. The good news is that these valves, they follow the name of the trunk and the vessel. There's a pulmonary trunk, pulmonic valve. This is the aorta, aortic valve. Perfect. Again, valves prevent backflow. They open and close in response to pressure changes. Now we'll talk more about the right atrium and how the anatomy of it receives blood from the circulation superiorly. So your upper body goes to the superior vena cava. Circulation of deoxygenated blood from your lower body, abdomen, lower legs, thigh, foot, all that goes up the inferior vena cava into the right atrium. So the right atrium receives deoxygenated blood from your body. And then if you take a look right here, there's a little indent right here. That is the opening or foramen, or right, sometimes known as ostia, right? So opening has a lot of different names, but this is called the ostia for the coronary sinus. And the ostia for coronary sinus allows us to bring deoxygenated blood from the cardiac circulation back to the right atrium, so then we can bring it eventually to the lungs to reoxygenate. Again, the blood that returns to the right atrium, it still has a little bit of oxygen, right? I don't want you to think there's no oxygen in it. It's just not 95 to 100% full of oxygen. And we want it to be 95 to 100% full. So that blood that returns to the heart that's somewhat deoxygenated cools in the right atrium first, goes through the right ventricle, and then goes through the pulmonary trunk and pulmonary arteries to go to the lungs, where it gets refilled with oxygen. It gets topped off with oxygen. Once it goes from the lungs, that oxygenated blood then returns to the left atrium by way of the pulmonary veins. This is the only time in the body where artery is blue and vein is red. Usually veins are going to be in blue, right? Veins carry deoxygenated blood back to the heart. Well, not in this example. There's a one time where we don't see that, right? Here, pulmonary veins, that's going to be in red. And this vein is going to carry oxygenated blood to the left atrium. Then it goes past the mitral valve to the left ventricle, up the aortic valve into the aorta. Keep in mind, as blood is coming back from the body into the right atrium, blood is also returning from the lungs, fully oxygenated to the left atrium. So it's happening concurrently. So again, as blood from deoxygenated blood from your upper body, lower body, and the coronary sinus, all right, as all that deoxygenated blood goes back to the heart and enters the right atrium, at that same time, blood that gets fully oxygenated from the lungs goes through the pulmonary veins, goes into the left atrium. And then as blood goes into the left ventricle on this side, blood is going to go from the right atrium into the right ventricle on this side. As blood gets ejected out of the left ventricle into the aorta, blood is going to get ejected from the left ventricle into the aorta. The blood is going to get ejected from the right ventricle to the pulmonary trunk. The big picture is it's happening together. The hard thing to understand is this. I just told you the blood pressure here is at 120, right? Why is it that we eject blood you have to somehow open up that aortic valve at 120? How is it that we eject blood in the right ventricle and the left ventricle at the same time, right? In the right ventricle, all we have to do is get to about 20 millimeters of mercury to open this valve. On the left side, we have to get to about 115 to open this valve. So that's a huge pressure difference, right? So how can they possibly open the valve and eject blood concurrently? Simple. The left side has more muscle. It takes just as long for the left side to open the aortic valve because it has more muscle as the same time frame for the right side to get to 20 millimeters of mercury and pop open the pulmonic valve because it has less muscle on the right side over here. Again, the muscular size is very important, right? In terms of the thickness and function, right? Atrial walls are very thin due to short distance for movement of blood to the ventricles. Ventricular walls are thicker because they have to pump blood to a greater distance. But keep in mind, the right ventricular walls are different than the left ventricular walls, right? Again, usually right ventricular wall pressure, we would say about 20 millimeters, 22 millimeters of mercury, right? Very, very low pressure compared to the other side. Why? Again, a combination of different things, right? One, because we're only carrying blood to the lungs here. And the second thing is because of the presence of oxygen. Oxygen vasodilates, right? Especially increased oxygen in the lung vasodilates the pulmonary arteries. Since they're fully vasodilated, it's much easier to move blood through. So you don't need to pressurize it as much. That's completely different on the left side. And here's a good picture kind of showing us the big differences. Look at how thick and solid that left ventricular wall is. Look at how small the right ventricular wall. AV valves, again, know them as the tricuspid and the mitral, right? And again, with all these valves, these are pressure valves. They open and close in response to changes in pressure. And we'll talk about those changes in a second. So this is kind of a cool picture to take a look at. This is the aorta right here. This is the aortic semilunar valve. And if you take a look real closely, you'll see little openings right here on the sides, right next to the aortic valve. These little openings are the openings to the left coronary artery and the openings to the right coronary artery. So what we normally see is the right and the left coronary artery, those are usually the only arteries that receives blood at rest, when the heart is at rest. When the heart is at rest, we say the heart is in diastole. So usually your radial artery, right, where your thumb is, where you take your pulse when you're exercising, that radial artery has blood moving through it in pulses when the heart contracts, when it's in systole. All of our arteries, except these two, the left and the right coronary arteries, all of our arteries receives blood when the heart is actually ejecting blood and moving it out of the heart into the aorta. In other words, it's in a systole that the arteries receive blood, except these two, right? Since it's found at the base of the aortic valve, the only time blood actually goes into the arteries is when you eject the blood up. That blood is moving really fast. There's no way that blood that we just ejected is going to go into these small vessels, these small openings here. But when the heart relaxes, blood that you ejected up a little bit comes back down. Because it comes back down, then it goes and opens and goes into the openings and into the left and into the right coronary artery. It's pretty cool. Now again, right, we're going to talk again about how things are going, and it's going to be kind of tiring because there's so much physiology in the heart. So it's not going to be easy to understand it, but it's also things that if you think logically, step by step, it should make sense. So let's talk about functions of the heart valves. Again, valves prevent backflow. So let's talk about what happens. Now this is just showing the left side. The right side also occurs in similar fashion. So as blood returns from the left to the left atrium, from the lungs, What's going to happen? Now there's more blood sitting in the left atrium than there's blood in the left ventricle, right? So the pressure in the left ventricle starts to dip, right? I've just ejected blood. I've already contracted. Now the left ventricle has to relax. It's in diastole, right? It's in relaxation. As it relaxes, the pressure in the left ventricle goes to zero. Zero, right? Because the pressure goes to zero, right? Now there's more pressure from blood coming back because of the aorta. That pressure from blood coming back causes the aortic valve to close. Pressure in the left ventricle, zero. Pressure on the, because now you have blood sitting on that aortic valve. Pressure to open the aortic valve is about 95 millimeters of pressure, right? Again, high pressure wins. In order to move blood and to open up the valves, you need to create pressure differences. Now the left ventricular pressure is at zero. You have blood coming back from the lungs, sitting on top of the left atrium. That's pressure, right? That weight is pressure. And what happens? Then at diastole, there's more pressure in the left atrium than in the left ventricle. The mitral valve opens up. As the mitral valve opens up, again, I'm just going to rewrite all these. As the mitral valve opens, blood from the left atrium goes into the left ventricle. Keep in mind, at the same time, on the right side, they don't show it, but I want you to think, it's the same thing. Blood from the right atrium from your body is going to be sitting on the right atrium, and that's going to create higher pressure than the pressure of the right ventricle. The higher pressure wins, and the tricuspid valve over here opens up, and blood from the right atrium goes into the right ventricle at the same time as blood from the left atrium goes into the left ventricle. Then what happens? As blood sits here, then we have a contraction of the heart starting at the apex. So we can see that initial spike on an EKG. Now what happens? When the contraction begins, it begins from the apex and then moves upwards, right? Now, as it squeezes upwards, what happens? It creates pressure. As it creates pressure, now there's more pressure in the left ventricle, right? Before, when it's at rest, left ventricular pressure was at zero. Now it receives the electrical stimulation to contract. When that electrical stimulation causes the muscles to eventually contract, it creates pressure. Before it's at zero, then it goes to 10, then 20, right? As it goes up, now there's more pressure in the left ventricle than in the left atrium. Just like squeezing a water bottle. Have you ever tried to open a water bottle with some of these Neo Aquafina water bottles that's really thin, right? The plastic is really thin. So you have to squeeze it and then kind of twist the top, right? But the plastic is so thin that sometimes when you twist the top, you're squeezing the bottom and a little bit of water shoots out as you open it. That's what happens here. If we create pressure from below, if the valve is open, what would happen? If I create pressure from below, all that blood will spill back out into the left atrium, right? We will have backflow. So what we need to do then is this. As the left ventricular pressure rises, and it needs to rise, as it contracts, as soon as left ventricular pressure exceeds left atrial pressure, all right? Usually left atrial pressure is about 10 millimeters of mercury. As soon as the left ventricular pressure goes to 11 millimeters of mercury, that causes your mitral valve to close. As a mitral valve closes, there's no backflow. Perfect. Now, there's 90 millimeters of mercury of blood sitting on the aortic valve. I'm only at 11 millimeters of mercury, enough just to close that mitral valve, but not enough to open the aortic valve. So what do? I keep contracting the muscle at the left ventricle. So it goes from 11 millimeters. I keep contracting, 20 millimeters, keep contracting and building pressure. Now it's at 40, and then at 80, and then at 90. Once it's 90 and then goes to 91, there's more pressure in the left ventricle than in the blood sitting on top of that aortic valve. High pressure wins, right? The left ventricle creates enough pressure, 91 millimeters of pressure. The blood sitting on the aortic valve creates a pressure, 90 millimeters of blood pressure sitting on top of the valve. So in order just to open that aortic valve, I need to go to 91 millimeters. The left ventricle can go up to 150, 170, right? It's very strong. So as soon as it creates enough pressure and it goes to 91, just slightly exceeding the aortic valve pressure, then I can pop open the aortic valve. As I pop open the aortic valve, I keep contracting from 91 all the way to 120, my systolic blood pressure. What does that do? It drives all that blood into the aorta, ejecting it with a lot of pressure, with a lot of speed, right? Then you're ejecting that blood out, and then the left ventricle has to relax. As it relaxes, the blood pressure starts to drop. As the blood pressure starts to drop, you go from 120 to 100, still forcing blood out. But once you get to about 90, you no longer are 92. You're ejecting blood, but not with a lot of speed, not with a lot of pressure. And what happens? That blood goes into the aorta. Aorta stretches a little bit, and now the aorta wants to, it's going to be acting like a rubber band. What happens if you stretch a rubber band? It wants to recoil, right? So the aorta does the same thing. Once it gets stretched, now it wants to recoil. We call that recoil resistance. So as blood moves up here, not very pressurized anymore, the aorta then recoils, causing the blood to move back down. As the blood moves back down, the pressure in the left ventricle goes lower than 90. Blood comes back downwards because of resistance, and it closes the aortic valve. And we start at this point again. All right, again, all right, so talking about the heart walls and the heart valves, I've already kind of talked a little bit about blood flow into the right and the left ventricles and atrium, and blood from the the ventricles into the great vessels, right? So take a look at this. It's kind of cool to see, from this view, you can really see the opening to the right and the left coronary arteries. And again, why is it that the right coronary artery, left coronary artery receives blood at rest, at diastole? Simple. At rest, blood is moving backwards. As blood is moving backwards, the aorta and its recoil is causing blood to go in reverse. As it goes in reverse, that blood then sits on top of that aortic valve and goes in to the opening to the right and the left coronary arteries. When blood is being ejected forcefully, that blood is going so fast, there's no way any blood can trickle back down here and into the opening to the coronary arteries. It is only when the left ventricle is relaxed that blood moves backwards because of recoil. As blood moves backwards because of the recoil of the aorta, then not only does it close the aortic valve, but the backwards movement of the blood allows blood to go into the left and right coronary arteries. Again, only arteries that receives blood at rest. Now, if you get confused, follow this, right? This one, number one, notice how it kind of looks like it's going in order. Goes from the superior inferior vena cava, goes blood, deoxygenated blood from the coronary sinus, from the cardiac veins, all empty into the right atrium. Then blood goes past the tricuspid valve into the right ventricle. That deoxygenated blood then goes past the pulmonary semilunar valve into the pulmonary trunk, into the pulmonary artery, into the lung. You fill up that deoxygenated blood, and then it comes back to the pulmonary veins. Then into the left atrium, through the mitral valve. Every time, I'm going to rewrite this just to make it a point. Pass the mitral valve into the left ventricle. Left ventricle then ejects that blood through the aortic semilunar valve into the aorta, to the systemic circulation, and into the coronary arteries. Now, you think it goes in sequence. It doesn't, right? As soon as blood goes into the right atrium, right, blood is going to go into the left atrium. So number 1 to number 2 occurs at the same time as number 5 as number 6, right? As blood goes from the right ventricle and gets ejected into pulmonary trunk, blood from the left ventricle gets ejected into the aorta. So it doesn't go in sequence, it happens concurrently. 1 happens at the same time as 5. 2 happens at the same time as 7, concurrently. Right, know this for the test. Again, everything that is highlighted, I want you to know this is an easy way to kind of gain points on this. The fibrous skeleton of the heart. So the fibrous skeleton of the heart is not a real skeleton. All right, I have students that tells me that it's a real skeleton. Your heart doesn't have anything skeletal, all right? No bones are found here. So instead, it's dense, fibrous connective tissue, really thick, really tough. And it's got 3 main purposes. Number 1, it forms a fibrous ring, allowing us to support the heart valves. Remember, the left ventricle is going to be ejecting blood under great pressure in order to prevent ripping of the aortic semilunar valve, prevent ripping of the tricuspid valve, the mitral valve. Right? To prevent ripping of those valves, you need something strong to anchor those valves in place. That's one of the functions of the fibrous heart of the skeleton. All right, fibrous skeleton of the heart. All right, let me just change the wording here. The fibrous skeleton of the heart. Another one, muscle attachment site. Right, in our skeletal muscles, we have bones to kind of, or it's where the muscles originate, and usually is where it also inserts, is on a different part of a bone. So you have an insertion and origin. You have an anchor, right, for the muscles to grab onto, for the skeletal muscles to pull on. Now in the heart, we don't have a real bone. Instead, the anchoring is that thick, tough, fibrous connective tissue that forms the fibrous skeleton of the heart. So the site for muscle attachment, for cardiac muscle attachment. The last one is incredibly important as well. So 3 main functions. This one I'm just gonna also underline because it's so important. It serves as electrical insulation between the atria and the ventricles. What we're going to see is that there is a synchronicity, right? There's an order to how we want the muscles to contract. Cardiac muscles are autorhythmic. In other words, if it doesn't receive any direction, it will contract by itself. We don't want that because now we're going to have asynchronous contraction. So when we want a contraction, we want ordered contraction. We want the atria to contract first, forcing blood, any remnant amount of blood, into the ventricles. The last thing we want is to have the atria and the ventricles contract at the same time. That's not good. We want the atria to contract first, ejecting any remaining amount of blood into the ventricles. And then we need the ventricles contract second, once the atria are relaxed. So we need that kind of communication. Atria first, then you have relaxation of atria, then the ventricles will contract. Right? So keep in mind, I think I just lost it right there. Keep in mind that when we have the atria contract first, we want to prevent that stimulation of the atria to get into the ventricles, right? All of these cells are autorhythmic. It's not unheard of for the atria to contract at the same time as the ventricles. So we don't want that to happen. So we need something that insulates the ventricles so then it will not contract at the same time as the atria. So then we have nice ordered synchronous contraction. Atria get stimulated, atria contract. Then we stimulate the ventricles. And as the atria relax, the ventricles start to contract. Atria first, ventricles second. Atria first, ventricles second. All right, that coordination is due to that fibrous skeleton of the heart. It prevents the action potentials from the atria to spread into the ventricles. Perfect. Now we can have ordered, right, synchronous contractions. Again, when we take a look at this, let me take a look right here. Right. I will kind of discuss a cardiac muscle, then we'll take a little break. Cardiac muscle, take a look at this, right? They're branched. They're smaller than a regular skeletal muscle, but they are striated. Now, the branch points also contains intercalated disc. So if you take a look right here, all these kind of black dots, right? It looks like all the muscles are going horizontally. And then you have a black line going vertically, right? The black lines are going vertically are usually found at areas that are branched. See that? Here's a branch point. You see one of those black lines. Here's the branch point down here, another black line. Branch point over here, black line. Well, the areas where you see branching, you see intercalated disc. Within these discs are gap junctions. So these gap junctions allow us to activate the cell. Sodium comes in, right? And as sodium comes in, because they're connected through a gap junction, the gap junction allows sodium to go from this cell to the next cell it's connected to, causing sodium influx in this cell, causing this next cell to also undergo an action potential, right? As it undergoes an action potential, sodium then moves to the next cell, causing the next cells to undergo action potential. So just by activating one cell here, I can activate numerous other cells it's connected to. That's how it's autorhythmic, is because they contain gap junctions, right? Now, besides the gap junctions found at the intercalated disc, they allow for communication. They allow for action potentials to move from one cell to the next, right? Besides that, it's very similar to a skeletal muscle. We even have the same arrangement of actin and myosin, same arrangement of troponin and tropomyosin. Now, I hope you guys kind of hit that pretty hard, right? What is troponin? What is tropomyosin, right? What is actin? What is myosin? We talked about that a lot in chapter 9, right? If you don't remember, please review a little bit of chapter 9, Amanda, right? Just remember actin and myosin, what it does. Talk about troponin and tropomyosin as well. I should have on my lecture videos some review, right, as we went through it in person, right? So please watch a little bit of both. I will have a new kind of slide, a new folder for voiceover PowerPoints like we're doing here, and then my in-person PowerPoints as well. So you have an option of listening to one or the other, all right? All right, let's take a little break.